Coming to the section of top 25 screenshot one-liners in cardiology. So this is for NEET PG. Evaporatin inhibits funny current. So we learnt there is something called funny current, pacemaker current. It helps in the phase 4 of cardiac pacemaker action potential. So evaporatin inhibits the funny current. Evaporatin is also a second line drug for angina management. Idioventricular rate is 40 per minute. Class 1A, Class 1C, Class 3 antiarrhythmic drugs cause QT prolongation. So Class 1A will be quinidine. Class 1C drug will be plicanide. Class 3 is amiodarone, dronidarone, etc. So Class 3 is a potassium channel inhibitor. Class 1 is a sodium channel inhibitor. So these two drugs, antiarrhythmic drugs, cause QT prolongation. Remember, Class 2 is beta blocker. Class 3 is Class 4 is calcium channel blocker. Mobitz type 1 AV block causes Wenckebach phenomenon, which is progressive prolongation of PR interval followed by a dropped beat. Inferior wall MI can cause AV block because inferior wall is supplied by the right coronary artery. Right coronary artery also supplies the right ventricle and right atrium. Also, SA node is also supplied by a branch from right coronary artery. So, inferior wall MI usually associated with right ventricular wall MI, posterior wall MI and conduction disturbances. Pulmonary embolism, the most common ECG finding is sinus tachycardia and the characteristic finding is S1Q3T3. Suspect pulmonary embolism when there is severe hypoxia in the background of some bedridden state or a surgery or malignancy with the DVT, and there is hypoxia disproportionate to their lung signs. So in our previous year NEET question discussion, this was discussed in question number 5. Narrow complex tachycardia with absent P wave and irregular RR interval is atrial fibrillation. Regular RR interval, it is AVNRT. So AVNRT treated with vagal maneuvers and adenosine. This was discussed in question number 4 of previous year NEET question series. For atrial fibrillation, rate control is the priority because in acute paroxysmal atrial fibrillation less than 48 hours alone, rhythm control is the priority. Otherwise, rate control is the priority, anticoagulation is next, and rhythm control is the last priority. This was also discussed in previous year NEET question series. Narrow complex regular tachycardia with absent P wave, but baseline ECG shows a Wolff-Parkinson White pattern, think of AVRT. Baseline ECG is normal, there is narrow complex regular tachycardia with absent P wave, think of AVNRT. Monomorphic VT occurs post-MI. Polymorphic VT, that is torsionis depointus, occurs in QT prolongation. Hypokalemia, hypomagnesemia, hypocalcemia, all these things cause QT prolongation, plus many drugs cause QT prolongation. Congenital long QT syndrome cause QT prolongation. QT prolongation leads to polymorphic VT. Tall T wave occurs only in two conditions, hyperkalemia or hyperacute MI. Hyperacute MI, we call it as De Winter's sign. This was discussed in question number 33 in detail. Mitral valve prolapse and HOCM, these two murmurs decrease with hand grip and increase with standing or Valsalva. Usually all murmurs increase with hand grip and decrease with standing, but think of the mnemonic vast hand. HOCM and mitral valve prolapse alone are two heart diseases which behave differently. Valsalva or standing will increase the murmur, whereas hand grip will decrease the murmur. Okay, D for decrease. HOCM and long QT syndrome, they are diseases which cause sudden death. Also we have Brugada syndrome. These are diseases which cause sudden death. This was discussed in question number 20. Infective endocarditis or papillary muscle rupture, these are the two common conditions which cause acute mitral regurgitation. Acute mitral regurgitation usually causes heart failure. Enterococci causes infective endocarditis following urological procedure. So there are different organisms causing community acquired native valve endocarditis, hospital acquired native valve endocarditis, early prosthetic valve endocarditis and late prosthetic valve endocarditis. So the 5 pillars of heart failure management are beta blockers, ACE inhibitor, ARB, ARNI and SGLT2 inhibitors. This was also discussed in one of the questions. In STEMI, first medical contact to PCI time is less than 90 minutes in PCI enabled centers. If for a referral center, the time is 120 minutes. Multivessel coronary artery disease, we prefer coronary artery bypass grafting either with the Lima graft, internal mammary graft, or with great saphenous vein graft. So convex ST elevation with reciprocal changes, it is MI. Concave ST elevation without reciprocal changes and with PR segment depression, it is acute pericarditis. If posterior descending artery of the heart arises from right coronary artery, it's called right coronary dominance. If it originates, if posterior descending artery arises from the left circumflex, it is called as left dominant system. If it arises from both, it's called co-dominant system. Cardiac tamponade versus constrictive pericarditis, think of the mnemonic PAID tags. In constrictive pericarditis, both X descent and Y descent are prominent, whereas in tamponade, only X descent is prominent, which means Y descent is absent. This was discussed in question number 21, and it was discussed in our complete cardiology revision series, also quick revision series. Stanford A or DBQ 1 and 2 aortic dissection is surgery because Stanford A, ascending aorta is involved. DBQ 1 is both ascending and descending aorta. DBQ 2 is only ascending aorta. So whatever it is, if ascending aorta is involved, the treatment is surgery. So these are some of our screenshot, 25 top screenshot one-liners.